So thank you for having me today. I really appreciate the opportunity to talk at the Newborn Screening Translational Research Network Summit. So I'm going to talk a little bit about sickle cell disease and informed consent for sickle cell disease, using this as a case study. Just to give a little background about sickle cell disease, it's the most common genetic hemoglobin disorder in the world. Millions of people worldwide suffer from sickle cell disease, and about 100,000 people in the United States suffer from the disease. And it's a chronic disorder, and if left untreated, it has devastating complications, and it's a progressive disorder. So children normally won't have as many complications, but as children age and become adolescents and adults, their quality of life, their pain, organ damage, it just has a whole cascade of complications associated with the disease. And it's caused by a single base mutation in the hemoglobin. And the thing about sickle cell disease is different from other diseases is most diseases, you have to have the identical base mutation. And so both parents have to give the child the same mutation. With sickle cell disease, one parent can be a carrier, can pass on the trait for sickle cell, and the other parent can have any other type of hemoglobin trait. So they can have sickle cell trait or C trait or beta thalassemia trait, and they can pass that on and the child will still have sickle cell disease. So it's a name for a group of disorders. And so if you fix that sickle gene, it fixes the disease. And so that's why it makes sickle cell disease an excellent candidate for gene therapy. So newborn screening has had a tremendous impact on sickle cell disease. Sickle cell disease can be the poster child for newborn screening, because prior to newborn screening, there was a large degree of mortality in infants with sickle cell disease. And if you look here, you can see that in 1979, there's huge bump in mortality or deaths in children with sickle cell disease. And the reason for this is because with the organ damage that was done by the disease, one of the first organs that was damaged was the spleen. And the spleen helps fight disease in children with sickle cell disease, helps fight bacteria. And one of the worst bacteria that children used to get was pneumococcus sepsis. And so that was one of the reasons that the newborn screening for sickle cell disease was begun, because centers, and St.Jude was included in that group of centers that tested giving penicillin to children by 2 months of age, and they found that it decreased the rate of pneumococcus sepsis and death by 84%. Newborn screening testing was recommended for sickle cell disease for all children. And now all 50 states test for sickle cell disease. And if you see, by 2006, that bump went away. And it's continued, the red line in 2014. So over 95% of children in the United States that are screened for sickle cell disease now live to reach adulthood. And so what's happening now? Now we have gene therapy, and we have gene therapy that is being in clinical trials and soon will become, I'm sure, will be approved for young adults. And now it's being tested in infants with sickle cell disease. And so you want to make sure that informed consent for gene therapy is clear, people understand, they don't have false expectations. And so we all know that the first thing you have to do is explain clinical trial and then explain alternative treatments and therapies. Well, when you think about gene therapy, it's complicated. It's complicated for clinicians who do not perform gene therapy. You have gene editing, you have gene correction, gene slicing, gene addition, you have ex vivo, you have in vivo. It is complicated to explain gene therapy. And you also have several drugs now that have been approved. So when you have alternative therapies, there is a whole plethora of information that you have to give. You also have to give the risks and the benefits, the logistics of gene therapy. How many times do you have to come in? How long do you have to stay to collect the stem cells? Your risk of infertility. What is the risk? Prior to your gene therapy, are you able to store your eggs? Immunosuppression. Are you in a facility where you can be isolated? The risk of death. There have been deaths with gene therapy for sickle cell disease. And the unknown risk. Gene therapy, any clinical trial, but especially gene therapy, has unknown risks. We won't know until time passes. And there's nothing that anybody can do for that except wait for time. And then the benefits. What's your expectation? What's a cure mean to you? Do you think you will no longer have any of the complications of sickle cell disease? If you had a stroke before, gene therapy is not going to cure the damage from the stroke. If you had avascular necrosis, it's not going to cure the damage. So setting expectations. And also, of course, one of the benefits is helping people in the future learn about gene therapy. But also you have financial considerations. Are you being paid for the clinical trial with gene therapy? What will happen if you have complications that are not related to the gene therapy? Who pays for that? Who do you call if something happens? Of course, confidentiality. And one of the main aspects of informed consent is voluntary participation. And so we all know some of the barriers are informed consents are long. They're lengthy, legalese. It's required by law. Certain elements have to be included. We know clinicians do not have enough time. We just went over all of the aspects that have to be in informed consent. And gene therapists don't have that kind of time. They don't have hours and hours to sit down with each patient and explain informed consent to the patients. And even if they do explain it, does the patient really understand it? And then we talk about bias. If you have someone who performs gene therapy giving informed consent, are they biased in the beginning? Don't they have a conflict of interest? Aren't they the ones who have a target for a number of people they want to participate in their trial? They have a hypothesis for what they think the outcome of the trial is going to happen at the end of the trial. How do you overcome the bias? And then one size does not fit all. Equity versus equality. How can you have the same consent for a person who is a PhD level or a person who didn't graduate from high school? You can't. It's an impossibility. You can't have one size fit all. You have to think outside the box with gene therapy and informed consent for gene therapy. And also, you have, by its very nature, the majority of people with sickle cell are in the US are African American and Hispanic, people of color. So that's a vulnerable population for health disparities. And we know that the average life expectancy for a person with sickle cell disease is 20 years less than the person without sickle cell disease. The rate of stroke in adults with sickle cell disease is 3 times higher than those without. And just funding disparities. For cystic fibrosis, which has 30,000 people in the United States, their funding is 27 times greater than the funding for sickle cell disease, which has 100,000 people suffering from disorder in the United States. So there's systemic disparity just because of the population. Also, you have distrust. The people of color have a huge distrust of clinical trials and the healthcare system. And it's been shown that only 5% participate in clinical trials overall in the United States, only 5% of African Americans. And of course, we all know Tuskegee and the syphilis experiment that went on and on and on. After there was a cure for syphilis, these Black men were continued to be studied and not given the medication. And we all have seen this with COVID. I mean, the people of color are hesitant, even though you have 600 million people who have gotten the vaccine. It's probably, we have the best safety data of any clinical trials and post-trial information, but people of color are still hesitant. And of course, just undue influence with people with sickle cell disease. There are not enough providers. And so if you don't have enough providers, if it's only one provider in your area who takes care of people with sickle cell disease, you don't want to be excluded or have that provider think badly of you, because they might put you out. And so that's in the back of patients' mind when they think about this. And adults have talked about this, and they talk about this with each other. And the majority are on Medicaid. And so that means poverty in and of itself for the Medicaid guidelines. And 70% of new providers do not accept new Medicaid patients. And so some of the attempts to overcome the barriers for informed consent for sickle cell disease have been to use plain language. And in essence, that means lowering it in most cases to a 6th grade level, reading level, to use online consents. Online consents, and I think most of us can attest that when we have those long online consents, most of us just click the agree button and go on to the next page. Even though it sounds like a good idea, most of us don't actually read the consents. Encourage longer informed consent discussions. Well, that's nice, but is it realistic? Are we going to be able to give the transplanters and the hematologists who perform gene therapy more time? Probably not. And including more team members. This is probably the one that's the most realistic, getting people other than the physicians and the nurse practitioners involved and teaching them how to give information for parts of the informed consent. Because if we can't teach our healthcare providers, how do we expect the patients to understand it? And so what if informed consent for gene therapy for sickle cell disease was reimagined? So the online modules and the written material is a good idea, but what if we made this mandatory? And when I say this, some people think, well, we shouldn't make anything mandatory. Well, we make tests for driving mandatory. Nobody gets upset with that. And that's driving a car. But think about, this is a life-altering decision. If a family cannot understand gene therapy, and if they don't have the commitment to go online and have video, we can have video, and in addition to the written material, then they probably are not going to be successful with gene therapy. Assigning the modules prior to gene therapy, because we all know that the gene therapists do not have the time to explain to everybody who might be interested in the procedure. And the hematologist actually doesn't know all of the technical logistics that go into the procedure. They can give an overview, but they don't know you might be there 8 hours, 8 hours a day to collect stem cells, and then you might have to come back 2, 3, 4 times. People have been known to quit just because they're tired of trying to get stem cells. Using the teach-back method, have them before they come to the gene therapist to talk, and it does not have to be a healthcare provider. It can be a volunteer. It can be a community health worker that they teach back and they explain in their own words what they think about gene therapy, what they think about the process, what their hope is for the outcome of this procedure. And of course, involve diverse team members. You are talking about a population that's mainly of color and having people of color help them, and also having someone who's been through the procedure talk to them about it, and then have a checklist so it's standardized for everyone. And we talked about just having community involvement. You can get your community-based organizations, your sickle cell community-based organization. Patients, we need patients involved, community health workers, and just thinking outside the box. So how does sickle cell newborn screening research help advance newborn screening research and newborn screening translational research network? So early identification, being part of the newborn screening conditions resource just is amazing. Having all 50 states provide information, because it's not just identifying, it's also following up. It doesn't do any good to identify if you don't follow up. And we've shown that if you can follow up by 2 months of age and put them on penicillin, it extends the lifespan. Community acceptance, having the information available for parents. The virtual repository, the parents can go in and find credible information on sickle cell disease and information about gene therapy and the ethics and the logistics of having therapy. And then it's a wonderful model for global expansion. As we know, most of the burden of the disease is in low-income countries, and having where they don't have newborn screening. So having a model that they can use to set up and start newborn screening in their countries is wonderful. We started worked with healthcare providers in Kano, Nigeria, and started a newborn screening program. And in 1 year, they tested at one institution, 3,000 children, and opened a under 5 newborn screening clinic, and already have 600 children enrolled in the clinic. Thank you, and I appreciate the opportunity. Here's my contact information. Feel free to contact me.